And this has been a nightmare for us as ART specialist, that you are having good quality embryos. There has been advancement of technologies, lab environment, the culture media, the culture technique, the other technological advances are there. So we can create good quality embryos. Still, you will see in some patients there have been implantation failure again and again. Now it becomes a real troublesome situation for the patient and the clinician also, where we are really sometimes at a loss what to how to counsel our patient, what to tell to them, and what can be the future direction in their management. So in this present next 30 minutes or so, I'll try to throw lights on this. That what are the causes of recurrent implantation failure? How to investigate or have a workup after recurrent implantation failure, and what can be interventions that can help to improve implantation rate. What is implantation failure? The failure of the embryo to reach a stage when an intrauterine gestation sac is recognized by ultrasonography. There can be two different situations to be called as or to be labeled as implantation failure. One group of patient where there has never been evidence of implantation, that was a negative HCG report or no detectable HCG production on blood or urine test. Or another group of patient who had evidence of implantation, that means we got a detectable HCG level, but it didn't proceed beyond that to the formation of a gestational sac visible on ultrasonography. That is what we call a biochemical pregnancy. Now, what is recurrent implantation failure? There have been difference of opinion or different school of opinions, I should say, about how to label some patient as recurrent implantation failure. So there has been no universally accepted definition. One author has mentioned as 3 failed IVA-PT cycles with good quality embryos transferred. Another author labeled is that after 3 unsuccessful IVF, specifically with 2 embryos of high quality. Another author has defined it as failure of clinical pregnancy after 4 good quality embryo transfers with at least 3 fresh or frozen IVF cycles and in women under the age of 40. So there have been variation in defining recurrent implantation failure in literature, but more or less we have taken it as 3 failed IVA-PT cycles with good quality embryos. Most commonly we use this definition. Now, as I have mentioned already, biochemical pregnancy falls into a category of implantation failure. Detection of HCG in blood or urine without subsequent clinical signs of pregnancy, that is biochemical pregnancy. 2 or more increased values of HCG that can be measured, yet there can be no evidence of gestational sac detected on transvaginal ultrasound 2 weeks later. They are all labeled as biochemical pregnancy. They are also one form of implantation failure. Now, factors which can be responsible for recurrent implantation failure. If we look at a broad classification, first group will be an endometrial or some uterine factor, and another factor can be embryo. Now we have to remember one thing, that in ART we are creating embryos and we're putting it back into the uterine cavity. So when there is an implantation failure, most common factors may be these 2, either with the embryo quality or factors in the embryo, or the endometrium or uterus, endometrial receptivity, I should say. Now, if you look at literature, in 1/3 of cases, 30 to 50% cases is maybe due to embryo quality or embryo factors, and other cases it may be predominantly uterine or endometrial factors, and there can be some other environmental factors, lifestyle factor or multifactorial etiology for recurrent implantation failure. But two most important factors are of course the embryo factors and endometrial or uterine factors. Now coming to endometrial or uterine factors, there can be anatomical factors like intrauterine polyps, fibroids, mostly intramural or submucous fibroids, adhesions, intrauterine adhesions, or Asherman syndrome, septum, or adenomyosis. Functional factors like thin endometrium, chronic endometritis is the leading cause of thin endometrium, and altered expression of adhesive molecules for several other reasons like endometritis or previous endometrial surgery, something like that. In some of the cases, thrombophilia, primary thrombophilia may be a factor for unexplained recurrent implantation failure. And some of the patients may have immunological factors like increased level of uterine natural killer cells, antiphospholipid antibody, autoantibodies, altered levels of Th1 cells, elevated levels of Th1 cells. You have to understand that this is one of the immunological mechanism for early pregnancy loss or implantation failure. That in endometrium, usually during implantation, Th2 means T helper cell subtype 2 are usually in elevated levels than Th1 cells. But in this group of patients, there may be elevated levels of Th1 cells, which may lead to recurrent implantation failure. Now, other local environmental factors may be there, like endometrial microbiota. In recent years, last 5-6 years or so, there have been a lot of interest on this endometrial microbiota, because sometimes there have been studies on that also, that if there is any alteration in endometrial microbiota, which is called a dysbiosis, that may lead to recurrent implantation failure even in a receptive endometrium. Then if there is evidence of PID, pelvic inflammatory disease, endometriosis of course can lead to altered endometrial receptivity. This is one of the mechanisms of endometriosis and infertility. And another very important factor is hydrosalpinx. If as we know, hydrosalpinx is collection of fluid inside the fallopian tube. They can also lead to, presence of hydrosalpinx can also lead to recurrent implantation failure by 3 mechanisms. One can be that mechanical factor, presence of hydrosalpinx, that fluid is itself embryotoxic, that can kill the embryos. Another can be that fluid can come into the uterine cavity and flush out the embryos. Third factor, hydrosalpinx can alter uterine receptivity or endometrial receptivity. So that's how it can cause recurrent implantation failures. So these are the endometrial factors which we should look for when there is recurrent. As I mentioned already, that endometrial factor plays a very important role in recurrent implantation failure. Now coming to embryo factors. As all of us know, that a good quality embryo or an euploid embryo is something is necessary for a implantation have a live birth. Now, if you now that age-old wisdom is that we know already that growth of embryo or cell divisions in embryo up to cell 4 or cell 8 stage depends on maternal RNA signals from the maternal RNAs, maternal RNA transcriptions. On day 3, there is activation of embryonic genomes, and that continues up to blastocyst or hatching. And then, so if you know, if you get a good blastocyst, so definitely there is more chance of implantation than a cleavage stage embryo. But regarding blastocyst, there may be a problem all of us encounter, that in a patient who are high responder, you have a choice. You can go up to a blastocyst culture, get a good blastocyst. But patients who are having a moderate or poor ovarian response, we may have fewer embryos to go up to a blastocyst culture. And other factors which can affect the embryo quality is parental chromosomal anomalies, particularly translocations right, Robertsonian or balanced translocations. Poor quality oocyte. We all know these with increasing maternal age. We get poor quality oocyte, and that will ultimately lead to a poor quality embryo or more chances of aneuploid embryo as maternal age increases. Some factor may be in the spermatozoa. When there is high DNA fragmentation or there is sperm aneuploidy, they can lead to a poor quality embryo. And then other factors in the oocyte like zona hardening, suboptimal culture conditions, suboptimal embryo quality, and suboptimal embryo transfer. All these may be factors which can lead to recurrent implantation failure. That should be our checklist. We should check all these. Now coming to environmental factors, I have mentioned already maternal age, because with increasing maternal age, there's more chance of aneuploidy, more chance of poor quality embryo, more chance of recurrent implantation failure. So gradually, I've already mentioned that they will lead to less chance of blastocyst formation, and these are the group of patients you may offer pre-implantation genetic screening or PGS in this group of patients. BMI, obesity or increased BMI may lead to recurrent implantation failure because it can affect two-site quality, embryo quality, and of course endometrial receptivity in some of cases. Smoking can be one of the factors which can lead to recurrent implantation failure, and another very important factor is stress. All of us know that our IVF patients are under a lot of psychological stress, so that stress itself can lead to recurrent implantation failures. Now coming to the prognosis, or how do we counsel our patients. Does embryo quality matter? Yeah, definitely. Quality of embryo matters in implantation. Quality of embryo at cleavage stage or on day 3 is graded based on morphology, basically equal or unequal size of cells, number of percentage of fragmentations, and on day 5 or blastocyst stage, it is based on the size of blastocyst, the assessment of the inner core mass, and trophoectoderm development. As I mentioned already, a blastocyst has more chance of implantation because I've explained already. So if there are poor quality embryos, there are more chances of implantation failure. But if they implant successfully, they have same potential for development and live birth as good quality embryos. Now coming to impact of sperm characteristics on recurrent implantation failure. Conventional semen analysis parameters do not accurately reflect sperm quality. Genome and epigenome integrity is essential for fertilization, normal embryo development, and successful implantation. Factors that can damage sperm DNA, cigarette smoking, genital tract infection, previous chemotherapy or radiotherapy, can lead to poor quality sperm, eventually poor quality embryo, and recurrent implantation failure. Association of DNA fragmentation and recurrent miscarriage is known, but its association with recurrent implantation failure is yet to be confirmed. But it has been observed in some studies that increased sperm aneuploidy can contribute to recurrent implantation failure. So you can go for these assays. If your patient is having recurrent implantation failure, we can counsel the patient go for a DNA fragmentation or sperm aneuploidy testing. And nowadays we know there is one technology, that is IMSI, intracytoplasmic morphologically selected sperm injection, which can detect a morphologically normal sperm before ICSI. And it has been observed that if the sperm is morphologically normal, then there is less chance of DNA fragmentation and aneuploidy. So IMSI can improve sperm selection that way in poor quality sperms, patients with poor quality sperms, and that can improve embryo quality. So IMSI is a new technology which is gaining popularity to deal with this kind of patients who are having problem on sperm characteristics and having recurrent implantation failure. Now another important aspect is endometrial characteristics. We know this concept, that is window of implantation. So that is the time period when embryo can attach to the biologically prepared endometrium. So after that they invade and they implant. Now the age-old wisdom is that after in a natural cycle, after LH surge, so LH surge lasts 7 days. Then window of implantation starts, or in a prepared cycle for when we are preparing endometrium for frozen embryo transfer, then it's P+5, that is on 6th day, that means 5 days after progesterone exposure, that window of implantation starts, and it remains open for another 48 hours, then it closes. That has been the traditional wisdom or traditional knowledge, and that's how we make our protocols for FET. And still, nowadays there has been interest in that, because we have seen that when we are going by that way and it's matching our criteria on ultrasound, that we are putting a good grade 1 endometrium, a good trilaminar pattern, and thickness is of course 8 millimeter or 9 millimeter, and even following this protocol, you are getting implantation failure again and again. So nowadays the concept is shifting, that we are thinking of doing an endometrial receptor assay to know that the patient is achieving that window of implantation on that right time or not. And several studies have been there. It is shown that 50 to 60% endometrium actually are in the phase or that window of implantation when we are deciding our date of FET. Almost 40% or so endometrium is out of that phase. There may be pre-receptive or there may be post-receptive endometriums. So crosstalk between endometrium and the developing embryo mediated by cytokines, interleukin 1, interleukin 6, and its product LIF, integrins, adhesion molecules, metalloproteins, growth factors, prostaglandins, and hormones such as HCG. So the factors which affect window of implantation always increase the chance of recurrent implantation failures. So now, what can be our investigations and approach to manage this kind of patients? Now coming to this role of diagnostic laparoscopy and hysteroscopy. Is there any role of diagnostic laparoscopy and hysteroscopy in recurrent implantation failure patient? Yes, of course. As I mentioned already, that this recurrent implantation failure patient may have a hydrosalpinx which has not been diagnosed till now. So if on TVS, transvaginal sonography, there is a suspicion of hydrosalpinx, always better to go for an laparoscopy, and if there is hydrosalpinx, go for the therapy, either clipping or salpingectomy. We need to counsel patient before we do the procedure. Then we can go for a clipping of the convoluted end of the tube, or we can remove the tube. So laparoscopy looks for, as I mentioned, external uterine pathology. External uterine anomaly suspected on USG or MRI can be confirmed using a diagnostic laparoscopy, and this is as it is diagnostic, it is therapeutic also. But one problem is definitely it's invasive and requires anesthesia, so it has all the complications related to anesthesia. But still, it will be helpful. And another group of patients, I think laparoscopy will be helpful in recurrent implantation failure is fibroid. And now leiomyoma, regarding leiomyoma, see, if you look at a literature, subserous fibroid usually doesn't affect implantation. But there has been debate about intramural fibroid, to go for an ET with an intramural fibroid or not. And there has been several school of thoughts, there have been difference of opinion in literature also. But if you look at recent literatures, you will see that fibroid and intramural fibroid of a size more than 4 or 4.5 centimeter can affect implantation. So in a patient who is having recurrent implantation failure and an intramural fibroid of more than 4.5 centimeter, we can counsel the patient for a myomectomy. While performing a laparoscopy, we can do a laparoscopic myomectomy in these kind of patients. That can improve implantation. So these two things I think are very important, to look for a fibroid or an hydrosalpinx and treat them on laparoscopy. Now coming to hysteroscopy. Now hysteroscopy is the gold standard to diagnose any intrauterine pathology. But now with advent of 3D volume probe on good quality machines, we can have a 3D TVS and we can estimate the cavity. If the cavity is reasonably okay on 3D TVS, then we don't need to do a routine hysteroscopy before every embryo transfer or before a first or second embryo transfer. But if there is recurrent implantation failure, this group of patient ideally should undergo a hysteroscopy before their another attempt, or fourth attempt, or fifth attempt. But it is its one advantage, less invasive, and also in the same sitting along with diagnosis, if there is a septa or polyp or adhesion, you can do these therapeutic procedures by hysteroscopy, and that of course can improve implantation rate. So incidence of abnormal hysteroscopic findings in women with recurrent implantation failure is between 25 to 50% on different literature. And as I mentioned, most common is polyp, septa, or some additions. So in recurrent implantation failure, it is considered as a routine investigation before another attempt at embryo transfer. And one thing about hysteroscopy, you have to remember that only diagnostic hysteroscopy will not help the patient. So if there is any problem like polyp, septa, and addition, it needs correction at the same setting. Now, genetic testing, role of genetic testing in context of recurrent implantation failure. It is indicated in nulliparous women with history of miscarriages or women or men with severe infertility. It cannot be made an universal test for all recurrent implantation failure because of high cost. Coupled with otherwise unexplained repeated IVF failures, there is 2.5% chances of carrying a balanced chromosomal translocation. So, in this context of genetic testing, another thing which often we counsel or we discuss with the patient also, that is pre-implantation genetic testing, that is PGT or PGS, pre-implantation genetic screening for patients with, because I have mentioned earlier that embryo quality, we know to get a successful pregnancy, we need an euploid embryo. More chance of aneuploid embryo, more chances of failure. So does pre-implantation genetic testing or PGS routinely before for a patient with RIF improves? There have been difference of opinion and something, but mostly there not have been much of significant difference in implantation rate, because you have to understand one thing, that pre-implantation genetic testing is not a, you cannot say that it will improve pregnancy. What it can help you, that when the patients like who are having more chance of like older age patient is more than 35 or something, where there is more chance of aneuploidy, before their embryo transfer, you can select the embryo by PGS. We have to understand this about PGS, that it helps us to select an embryo for transfer. So if you get a good quality euploid embryo, then go for the transfer. That way it helps. But it cannot be like a knee-jerk reaction that for every RIF patient you have to suggest that patient has to go for a PGS or pre-implantation genetic screening. Now, importance of good cryopreservation program. Long-term storage of structurally intact living cells or the embryo helps to defer embryo transfer until a later time. Oocyte cryopreservation offers more advantages compared to embryo freezing. Fertility preservation in women on oncological treatment or chronic disease, egg donation, postponing childbirth, eliminates religious and other ethical, legal, or moral concerns of embryo freezing. Now, another strategy regarding this embryo that can be helpful in recurrent implantation failure is assisted hatching. As we know that some of the oocytes may have a zonal hardening or something, so there may be problem in the hatching also. That can be factors in some of these patients. So there has been this attempt for quite a long time for assisted hatching. It can be done by 3 techniques commonly. This is a mechanical, you can cause a partial dissection of the zona, or it can be a chemical using thyroid solution or something like that, or you can use a laser. Now there has been not much of randomized controlled trial or big studies to compare these techniques, these 3 techniques, to say which technique is better or for assisted hatching or something. But definitely laser has been the preferable technique for assisted hatching. So in selected group of patients, this assisted hatching can be helpful in improving implantation. Another technique can be used in the lab also is for embryo co-culture. That means if you culture your embryo along with an tubal epithelium or endometrial epithelium, that can improve embryo quality. There have been studies on that, there have been literature on that. There can be improvement of embryo quality, maybe less fragmentation of the embryos. So that can be a useful intervention or strategy in recurrent implantation failure. Now coming to role of myomas, I have discussed a bit already. That it causes physical hindrance in implantation. There is increased intrauterine contractility, deranged cytokine profile, abnormal vascularization, and chronic endometrial inflammation. All these may lead to that. So if there is about myoma, I can tell you, if there is a submucous fibroid, there is no controversy. You have to do a hysteroscopy removal of the submucous fibroid before you attempt an embryo transfer. If it is intramural myoma, then size more than 4.5 centimeter, we can consider a myomectomy. If it's a subserous myoma, it doesn't affect implantation per se, so it doesn't require a routine removal before an embryo transfer. Now coming to another concept, that is endometrial injury or endometrial scratching, that is known amongst clinicians that way. So causing injury to the endometrium prior to implantation, it causes desegregation and increase in local cytokines involved in wound healing, and these cytokines actually helps in proliferation of endometrium and increases vascularity of the endometrium that can improve implantation. That is the hypothesis behind this concept of scratching or causing endometrial injury. Now, there have been studies on that. There have been reported studies on that, although there are small studies. There's not proper randomized control trial on that, but there have been studies which have claimed that implantation rate of patients who underwent biopsy or endometrial injury prior to IVF cycle or no injury cycle, there have been an increase in implantation rate or pregnancy rate in patients with endometrial scratching group and injury group. But there has been no agreement on what degree of injury or the number of injuries when in the menstrual cycle it should be done, although it's a common practice to do in the preceding cycle. On day 7 of the preceding cycle, you can do it. Most common method of doing an endometrial scratching is to use a people's endometrial biopsy forceps. But again, as I mentioned, there has been insufficient evidence or literature because you don't get much of randomized control trial or meta-analysis, all this. What we get from literature is mostly observational studies or smaller studies with power. Now, there have been certain empirical therapies like immunotherapy with intravenous immunoglobulin, but again, there has been controversial results on IVIG or immunoglobulin. It improves pregnancy rate after recurrent implantation failure or not. Now coming to cellular mediators or in recurrent implantation failure, because I'll finish my discussion now. I'll go into the endometrial receptor assay. That's a new concept that is coming. So we see that there are higher concentration of IFN gamma, interleukin 1 beta, interleukin 6 or interleukin 4, and higher ratios of pro-inflammatory and anti-inflammatory cytokines, and there have been lower concentration of TGF beta 1 in patients with recurrent implantation failures. Now, coming to this concept of endometrial testing or endometrial receptivity analysis or endometrial receptivity assay, as I have mentioned already, that we know that there is a concept of window of implantation. Some of the times it happens that actually there is a good quality embryo. Clinically, we are thinking that endometrium is good, it is prepared, but it is still in the pre-receptive phase, or it can be in the post-receptive phase. That purpose of endometrial receptor assay is to diagnose that how is the preparation of the endometrium, that is being prepared or not, and according to the report of endometrial receptor assay, you can have an personalized embryo transfer, that is PET, can be planned for this kind of patients with recurrent implantation failure. So it's a molecular based test diagnosed to date the endometrium. It claims that the endometrium is exactly on oocyte cycle day 20 will improve implantation rates. To achieve this accuracy, the error requires an endometrium receptive test result. That is, it's matching that rate. Rest of them either were pre-receptive or post-receptive. So according to that report, we can plan an endometrial embryo transfer. Second generation ERA markers specific to endometrial glands and maternal immune implantation response marker can improve accuracy. Now coming to inflammatory marker testing, is there any role of doing inflammatory marker testing in recurrent implantation failure? Of course, there people are trying. You collect an endometrial biopsy anytime from LH search, 6 days after LH search to 10 days after LH search in a natural cycle, or 5 days after progesterone exposure to 10 days after progesterone exposure in a stimulated cycle or an HRT cycle. It focuses on the immunohistochemical expression of B cell, CLL, or lymphoma marker of endometriosis, or treatment of endometriosis following a positive receptive inflammatory marker test will improve pregnancy outcomes. Now, endometrial function test, it has two components, a histological assessment and an assessment of endometrial development. It determines the developmental state of endometrium by quantitative immunohistochemical assessment of a molecular marker of proliferation, that is cyclin E, and a marker that stops proliferation is P27. By examining a panel of markers in patients' endometrial glands on between cycle day 15 and day 24, the developmental trajectory between these days can be deduced. Women who had an abnormal EFT with no form of intervention were 10.5 times less likely to have an ongoing pregnancy um, because they are out of phase, the embryo will not implant. So, but the limitations that 2 biopsies are required for processing of specimens. This very laborious process and time consuming also, and you need an expert reproductive pathologist to assess the slide produced for the test. Summarize all this. Recurrent implantation failure is a failure of clinical pregnancy after 4 good quality embryo transfers with at least 3 fresh or frozen IVF cycles in women under age of 40. There are endometrial or uterine factors, gamete or embryo factors, or other environmental or lifestyle factors. Poor quality embryos, higher chances of implantation failure. But if successful, has same potential of live birth. Palm characteristics and endometrial characteristics have a role to play in recurrent implantation failure. Hysteroscopy is the gold standard for diagnosis and also for therapy for any intrauterine pathology or abnormality. And routine PGT or karyotyping is not indicated. It is on case-to-case basis. Role of immunotherapy is controversial. There have been various tests of endometrial receptive off-rate, molecular dating, endometrial function or inflammatory marker. But as you know, these are in the stage of development, and cost and also technical difficulties are an aspect. Hope this test can give some guiding light for us in future to have a perfect implantation. Thanking you. Thanks, all of you.
Yes, sir. Thanks for your valuable insight on this topic, recurrent implantation failure. I would like to request to viewers, if any questions in your mind, you can ask to sir. You can unmute yourself and ask questions to sir.
Hi, Dr. Rahman. This is Dr. Anupma.
Hi. Hi. Good afternoon, Dr. Rahman. Fine.
Very good presentation. The slides were excellent. Your deliberation was very good, and I heard most of it. So, congratulations. Very good talk.
Thank you. Thank you.
Thank you. Okay.
Thank you. Any others? You can unmute yourself and ask two questions to Dr. Rahman. Sir, I think there is no question.
Okay, then we can stop over here. Anyway, thank you. Thanks, all of you. Okay, then I'm leaving the meeting.
Okay, sir. Thank you, sir. Take care.